Hey everybody, it's Tom Judd here from IFMB CED and also part of the GCEA Founders Council. And I've got Shauna Mullally here today, one of the Founders Council members. And so Shauna, tell us about your what you've been doing over your career.
Sure, thanks, Tom. I'm really happy to have the opportunity to chat about this. I'm from Canada originally. I would say I started my career in clinical engineering with my master's research at Carleton University in Ottawa. I was working with a very well-known, accomplished clinical engineer named Dr. Monique Fries. And what I was actually looking at for my thesis research was I was studying the effectiveness of clinical engineering services in hospitals in low resource settings. So Dr. Fries years before had done a model to predict outcomes of effectiveness for these services in high resource settings. And I took her model and said, what's going to be different and what's going to be similar in low resource settings? Yeah, that's where I first got really excited about the field of clinical engineering. I went and did some research for my master's in the Gambia in West Africa, working with Kevin Taylor at the Medical Research Council there. And then when I finished my master's, I went back to the Gambia because I had such a good time there. And I eventually took over running the biomedical engineering department at the MRC. That was really fun. I had a team of techs. We had a workshop. They managed all the maintenance and I did the kind of management for our health technologies and medical equipment that we were bringing in there. And I just honestly, I loved working there. Like, it was really busy. There was never a dull moment. We supported sites across the Gambia and a research site in Guinea-Bissau as well, where they researched HIV-2, a different strain of the virus. And yeah, it just really gave me the best possible kind of baptism by fire into the challenges delivering clinical engineering services in a low resource setting, and I loved it. Then from there, I moved to Southern Africa to do some work in Zambia with a really great organization called THET, or the Tropical Health and Education Trust. THET has been working for a long time based out of the UK in certain countries around the world on partnerships. So when there's a partnership between a hospital, say in London, and a hospital in Ndola, Zambia, and their main focus is training of health professionals. It started with physicians, and then it expanded into midwives, different specialties of nursing, pathology, anesthesia. And then eventually, when I started doing work for them 10 years ago, they had started looking into how to engage more in clinical engineering. So that's what I was doing for them in Zambia. It was really fun. I did a kind of mapping across the country in the health service for what types of human resources were most in need in Zambia, because it's very common in low resource settings to really not have enough people working in the area, to not have enough positions, to not have enough people who have access to training. And that led to the development of the first diploma course in Zambia. It's just under a 4-year diploma program. And it was a real privilege to be involved in getting that program up and running. And at this point, it's had graduates, I believe, for the last 5 years already. So that's quite exciting. That program is really well run, and it's an amazing example of a solid training program that's built on exactly what a certain health system or country needs. I also did a lot of work for THET based in London. A lot of that was looking at supporting UK hospitals and UK charities that were doing work overseas with medical equipment, and kind of giving them good practice guidance when they were donating equipment. We wrote a handbook called on good equipment donation practices called Making It Work, which was based on the WHO guidance, and then was kind of more specific to the UK context and more kind of something that people could take and actually put easily into practice. And yeah, worked on a grants program to support these partnerships between clinical engineering departments in the UK and partners in 5 different countries across Africa. So I really enjoyed that. I did some other work in other countries in Africa and some different work in Zambia as well, mainly around like needs assessments. So needs assessments for equipment, needs assessments for clinical engineering professionals in different places, making recommendations for what types of training opportunities could be leveraged or utilized to try and really upskill some of the technicians and technologists working in different countries, and some suggestions for how to build up like a biomed workshop, how to build up that capacity in hospitals. And I really, yeah, I just really loved that work. And then from there, I moved to Copenhagen to work with UNICEF at their supply headquarters. And I was there for 2 years. I was working as a medical equipment specialist for procurement, so for technical evaluations of tenders for both equipment and kind of these medical kits. But while I was there, the Ebola outbreak in 2014 happened. So I ended up being really involved in the response. And it's funny, like, I mean, most people think of clinical engineering and they think about equipment. And while that's most of what we do, there were a couple of us who were clinical engineers at UNICEF who were trying to really quickly become experts on standards for PPE for Ebola, because PPE is often classed as a medical device. And we were trying to apply our technical knowledge basically to try and quickly figure out what we could procure and what would be appropriate to send to the field. And I went to Guinea as part of that response and did some supply planning. And in terms of the skills that clinical engineers bring to different fields, like I was doing supply planning for PPE and equipment for these treatment centers that they were setting up. But I really do feel like our skills as clinical engineers, our kind of systems thinking approach and our focus on problem solving can be and is often kind of applicable beyond the specific realm of our area of work. And then 4 years ago, I moved up to Yellowknife in the Northwest Territories in Canada. So I came back to my home country. And where I'm living now is really interesting. It's kind of, Canada's a high resource country, obviously, but parts of the territory where I live have real challenges. And we have very kind of small, geographically isolated communities where we have a lot of health centers. So we have a lot of the challenges that I used to see and work with when I was overseas in different places in Africa, in terms of we, instead of not being able to ship things in because it's too hot, we can't ship things in the winter months here. And we have some challenges in the health system here retaining staff at very isolated locations as well. And a lot of different models for like telehealth and things that make sense in other countries I've worked in, and also happen to make sense here in the North in my home country. My job here, I manage a team of all clinical engineers and technologists, and we do all the equipment planning and procurement for the health system. So we have a great model up here. My team works very closely with the biomedical engineering team that's based at the hospital here in Yellowknife that provides maintenance services. So they're like the frontline clinical engineering service, and we do all the planning and procurement. So we take the first half of the life cycle of equipment and they take the second half, and we work incredibly closely together. It's a really effective kind of partnership for our area. The biggest project that I've worked on here to date was the building of a new hospital here in Yellowknife, a new 100-bed hospital, which is we're a pretty small place. That's our biggest hospital. It's our referral hospital. And it opened its doors in May of 2019. So we did all the equipment planning for that and helped get everything commissioned. And it was a pretty exciting project. Last year, my team worked a lot on the kind of equipment planning for the COVID response as well. And now most of our work is focused on our planned capital replacement budget that we manage. So we get to go and do a lot of work with the users in different clinical areas to map out their requirements and implement projects.
Wow, Shauna, amazingly deep and wide experiences you've had. And although most people aren't going to get that many passport stamps like you have, and you've spoken to this a lot, what would you say, the clinical engineering's role in the LMIC setting? I mean, any other comments you'd add to what you said?
Yeah, good question, Tom. I feel like I've been very privileged to work lots of places, and I've met lots of people working in our profession. Sometimes the people who I've met have an engineering degree that they've either gotten in their own country or they've maybe gotten overseas. But there are lots of low resource settings where there actually isn't a clinical engineering program or even necessarily an engineering degree in the country. And there may or may not be specific training for biomedical engineering or clinical engineering at the college level either. I think for any clinical engineer who's interested in doing work in other countries or specifically in low resource settings, there's a lot of really exciting work around new programs that have started up. So either like teaching at a new program or helping to develop the curriculum for a new college program somewhere, working in partnership with an institution somewhere more high resource. And I also think, yeah, the work that I've been lucky to do and the people that I've gotten to work with in different countries, like specifically, I'd say my most extensive experience was in the Gambia and Zambia. There's a lot of kind of advocacy work that's required. I think clinical engineers kind of all over, and especially clinical engineers in our field who have been around since it became a field, who have decades of experience to share, will talk about the challenges of being recognized as a profession when it was starting out, and sometimes the challenges that are ongoing in terms of recognition within our own kind of hospitals and health systems. And I think that that's an even more kind of crucial, I think it's an even more crucial gap at times in low resource settings. Like I've been to lots of hospitals where I'll kind of meet the maintenance team who are managing equipment, and then I'll have a meeting with the hospital administrators, and it's the first time those people have met. And I know you could say that happens in high resource settings too, and it does, but there's a real there's a lot of focus in low resource settings on acquiring new technology, and there's a real dearth of understanding from donors who are providing equipment often, and from programs where equipment introduction is a big part of them, a big kind of dearth of thought or understanding about what's required to keep those pieces of equipment, to get them running in the first place, and to keep them running and make sure that they're safe and that they're actually doing their job. We clinical engineers talk a lot about the iceberg model, like the acquisition cost and the kind of work to acquire the right technology, and the cost of it being what you see above the water, and the mass underneath being the actual resource required to keep it running and make it a useful investment. And I think that under the iceberg part is particularly a challenge in low resource settings where budgets are really stretched, and often people have knowledge, but they can't access the parts. There's no budget for it, or they know what to do to try and test something, but they just don't have the right test equipment. So I would say, yeah, any clinical engineer from somewhere high resource who's interested in doing work overseas, there's lots of work to be done, and you get to work with great, really, really bright people who, and it's a great feeling when you're able to help them access some resources to do their job that they really need.
Again, some deep and wide experience that you're sharing. Let's go a little deeper, though, on the LMIC, the low middle income, low resource country experience around donations, and so maybe some recommendations that you'd see from that, and your capacity building of talent in our CE practitioners in those places.
Sure, yeah. So equipment donations are a really big thing in lots of low resource settings. And it's interesting, like globally, I find things have changed a lot with COVID, to be honest, but pre-COVID, there's lots of kind of stuff in the news around like drug access, pharmaceutical access in low resource settings, and the cost of pharmaceuticals and challenges, regulatory challenges with pharmaceuticals, and equipment. Medical equipment has lots of the same challenges, but hasn't always gotten the same airtime. And that's mainly because it's a little bit more complicated. I think it's more complicated once equipment shows up somewhere for it to be utilized in the right way than pharmaceuticals are. But there are different statistics from various studies, but basically the kind of going stats are that like lots of low resource settings kind of sometimes half or sometimes the majority of equipment that's in a health system in a low resource setting has arrived there through donation. And there are big challenges getting donated equipment to actually work well, and having donations that happen with enough kind of thought and resource for the maintenance of them to be factored in early on. And so donations are generally a really big act of generosity, and there are some donation organizations where that's their job, that's what they do, and they tend to be fairly effective in terms of matching actual needs on the ground, thinking about maintenance, because there are often clinical engineers who work at these organizations, and making sure that donations are done effectively. But I've also, unfortunately, in my experience, seen lots of donations that have happened with little to no consultation, and without like the right resources to get equipment going, let alone keep it running. So there is, yeah, I find like if you think about whether you're in a low or a high resource setting, if you think about someone coming and just kind of dropping some stuff that they had that they don't need anymore on your doorstep without saying, oh, hey, do you need this? I'm giving this away. It's kind of a funny thing to think about. And unfortunately, that still happens. I would say there's lots of, like I said earlier, there are lots of organizations that do donations well, and there's lots of guidance as well, including the WHO guidance on how to do donations more effectively, because the reality is in resource poor places, they're still often a really big source of equipment, of much needed resources, and they can be managed very well. But what I would say to anyone who's involved in a donation is seek out that good practice guidance, talk to people, and really start by not saying, I have this to give, but saying, what do you need? Like to the partner organization or hospital you're donating to, what's actually going to help them improve their service delivery? And to always factor in maintenance, like don't donate oxygen concentrators without making sure that the technicians there have an oxygen meter that they can use. Don't donate lab equipment without knowing that they can buy consumables and reagents in country. So yeah, there's a lot of good guidance out there. Oh, and also, Tom, you asked about training and capacity building. Yeah, I think there have been really interesting things happening in places where there aren't a lot of educational opportunities for people. So there are new kind of college programs springing up. There are some established college programs and university programs as well. And one thing I'm really excited to see is that I've noticed over the last 10 or 15 years is a lot more opportunities for people to kind of travel within their regions in low resource settings and train each other, and a lot more training opportunities that are looking at bringing in trainers from other similar locations, as opposed to always bringing in trainers from higher resource settings. There's also like in terms of clinical engineering organizations and associations, there are lots in lots of countries, and there have been opportunities over the years for example, all of the African biomedical engineering associations to get together to share their experiences, figure out how best to collaborate with one another. And yeah, I would encourage more of that. I think some of us are lucky enough, we happen to be from places where there are lots of training opportunities that most people can access, and other people are not as lucky and tend to not have the same types of opportunities. And so I think anything that helps create more opportunities for people who would like to work in our profession and understand what a contribution we can make, the better.
And last question, great answers, by the way. So I know, why'd you join GCEA? What vision do you have for GCEA? And I know you're a leader among, clinical engineers, male or female. I love the program a month ago we did, where you were among those that highlighted women's contributions. What are your thoughts about the Alliance?
Yeah, thanks, Tom. I would say two things. I joined the Alliance because I think, as I said at the beginning, I think advocacy is also a really big kind of part of what we should and could and can be doing as clinical engineers. And I wanted somewhere where clinical engineers the world over could be part of something that was focused on clinical engineers specifically. And I think that there is so much, we have such a big opportunity to share information, to collaborate globally. The work that IFMBE CED has been doing has been great. And the idea of having the Alliance be a place where training, body of knowledge, body of practice, certification, programs to promote partnerships and equality and inclusion, where all of that can come together and be focused on our profession, is a wonderful thing. And yeah, I've been very lucky. I had the opportunity, as I mentioned at the beginning, to work under Dr. Monique Fries, and she was a real leader and visionary. She did so much work over the decades to promote women in engineering here in Canada, and I was really lucky to work with her. And I got to work on and start up a couple of programs when I was at university to promote engineering to girls and young women. I would say I grew up in a family of teachers. I'm very lucky, but I didn't grow up in a family of engineers. And I got into engineering because I loved math and science, in particular physics, in high school. And so I feel lucky that I kind of stumbled into it because of that. But I would say in general, it's hard to be what you can't see. You can't be what you can't see. And so I was lucky to work with a few really impressive women, including Adriana Velasquez at WHO, who's I think impressive to everyone. She's just a real visionary and like really passionate advocate for our field globally, and we're lucky that she's there. But I think the more diversity we see in our field, the better. I feel very strongly that professions should always reflect the people that they serve. And I think it's important that we both celebrate and promote inclusion in our profession. And that's another reason I'm really happy to be part of the Alliance, is that I see a big role for us as an organization in promoting people who have been traditionally underrepresented in our profession, not just in the countries that we're all from or that we're working in, but globally. I see that as a real opportunity that we have as an Alliance, and I'm really happy to be working on it.
Well, we had some fun together today, Shauna, and thanks for your time, and looking forward to seeing what the Alliance will do.
Yeah, thanks so much, Tom.